Hi guys, welcome back to week 7. We are now in the module for cardiovascular review. So there's about 35 slides in this PowerPoint presentation. I'm going to try to get through it quickly. Please, I would advise and suggest that you have your textbook, your Dumphy textbook in front of you, because I'm going to refer to some tables and some content in your text that I would like to make sure you are aware of that you are reviewing. All right, so here we go. So I just wanted to review what chapters we are currently reviewed for this particular module. I did ask that you please go back and review chapter 34, quick skim, just to make sure you are comfortable with differentiating the common cardiovascular complaints. We did review that last semester, but just as a basic review for the next few chapters, chapters 35 and 37. As well as the chapters from your practice guidelines and your advanced practice procedures. So in chapter 35, the focus is on cardiac and associated risk disorders. It looks like a lot because I really took out everything I really wanted to make sure you focused on in your textbook, and I really wrote it out clearly within the module. So don't get overwhelmed. That's just kind of a guide to make sure that you are reviewing each of these particular topics extensively via your text. So I thought this might be helpful just as a guide in terms of guiding your studies. So we're going into hypertension, metabolic syndrome. Make sure you review the drugs commonly prescribed for hypertension. They're listed beautifully in the table within your textbooks. Same thing with dyslipidemia, table 35.3, 35.4, excellent resources in terms of differentiating the different types of treatments and diagnostics. You want to make sure you're reviewing the drugs commonly prescribed for statin therapy. You want to make sure that you're understanding coronary heart disease and the clinical manifestations, as well as complementary therapies for cardiac conditions. Acute coronary syndrome, make sure you look at table 35.5 to differentiate the different forms of angina. Make sure you're localizing an MI on an EKG. Look at table 35.6. Please review that. You may not be so great at EKGs and understanding them and being able to analyze rhythms, but that being said, you should be able to differentiate just by sight certain types of arrhythmias and obviously danger signals in terms of an MI and a STEMI or a non-STEMI. So make sure you look at table 35.6. You want to make sure you understand how to treat angina versus an MI. And of course, table 35.7 to differentiate heart failure. And you're going to definitely want to make sure you understand the classification of heart failure severities and the staging criteria for heart failure as well. Okay, chapter 37 got into disorders of the vascular system. And here you are definitely reading on peripheral artery disease, or PAD, the risk factors of PVD. You want to be able to differentiate arterial versus venous risk factors. You really want to make sure you are clear on education in terms of peripheral artery disease. You definitely want to make sure you're understanding deep vein thrombosis and the risk factors specifically, as well as understanding Virchow's triad and what kind of education you need to provide to your patients with DVTs. In your CASH Family Practice Guidelines book, you got into understanding your guidelines for treating an MI, an acute MI, atherosclerosis and hyperlipidemia. You want to review table 10.1. Chest pain, heart failure, hypertension. There are some beautiful tables to review within your guidelines that are really helpful in differentiating and treatments, like type algorithms to give you guidelines. In your advanced practice nursing procedure book, you are reviewed how to do Doppler techniques, EKG interpretation, EK lead placement. Just keep in mind, I did put quite a few EKG supplementary videos from YouTube in terms of interpreting EKGs that were great. I actually used those when I was in grad school. I put them in the dive deeper section. Some of you might be really good with EKG interpretation. Some of you, it may be new to you because it's just not something you do in your practice, but it is something as a nurse practitioner that is a basic standard of care that you should be able to do and interpret. So just make sure you review those videos if you still struggle with EKG interpretation. There's an entire website, an entire YouTube channel specifically to those videos. I think I only uploaded like the first 3 levels or the first 3 courses, but he has a whole bunch. I think they go all the way up to 7. So feel free to use those for future studies. You also reviewed Holter monitor application, stress testing, the different types of pacemakers. In terms of procedures, you reviewed arterial puncture, blood culture specimen collection, central venous catheter access, defibrillation, Unna boot application, and venipuncture. So again, if any of these things are unfamiliar to you, or just really you've never been exposed to any types of these procedures or any of these diagnostic tests, please feel free to look on YouTube to just get a quick visual, because they have really quick 3 to 5 minute videos going over these particular things. I specifically just uploaded the things that most people struggle with the most, which is usually the EKG interpretation. Okay, so in terms of the heart, cardiovascular system, as usual, I always like to do just a quick basic review of the anatomy and just review the normal findings, because remember, it's important for you to review the normal findings and know the normal findings so that you can differentiate the abnormal findings or new abnormal things that have crept up on your patient as they present to you. So, in terms of your common cardiovascular anatomy and normal findings, you want to make sure you're reviewing the anatomy, the position, and the normal findings of the heart. So remember, the right ventricle is the chamber of the heart that lies closest to the sternum. The lower border of the left ventricle is where the apical impulse is generated, and the heart is roughly the size of a large adult fist. The apex beat is caused by the left ventricle. Remember, your apical impulse is located at your 5th intercostal space by the midclavicular line on the left side of the chest. You want to remember that your displacement of the point of maximal impulse is usually caused by your left ventricular hypertrophy, cardiomyopathy, or pregnancy in your 3rd trimester. We want to make sure you have reviewed your heart sounds. So your S1, your systole, which is the sound of love, and then your S2 diastole, which is the sound of dub, of love dub, and that's your closure of your aortic and pulmonic valves. For me, guys, as a study tip, one of the things I did was go ahead and get a diagram very similar to this right on Google Images. I downloaded it on the internet, printed it in black and white, and then I personally labeled my heart, as well as added all my notes to my heart sounds that were normal versus abnormal, and just wrote a lot of notes on this particular diagram that I printed online, just so it was just a really helpful visual guide in really trying to understand, where the heart sounds were located and where I was hearing abnormal heart sounds based on the arrhythmias and the heart murmurs. So you definitely want to review your S3 heart sound versus your S4. Remember, your S3 is usually indicative of heart failure or congestive heart failure. It sounds like Kentucky, versus your S4 heart sound usually indicates left ventricular hypertrophy, and it's sometimes considered normal in elderly because it's slight stiffness of the left ventricle. It sounds like Tennessee, and it's best heard at the apex or the apical area, also known as the mitral area. Okay, using the bell of the stethoscope. You want to make sure you're very clear on your stethoscope skills, including bell versus diaphragm. Remember, your bell of your stethoscope is where you hear your low tones, such as your extra heart sounds, your S3, your S4, and usually you can hear best mitral stenosis with the bell of the stethoscope. Versus the diaphragm of the stethoscope is where you hear your mid to high pitched tones, such as lung sounds, your mitral regurg, and your aortic stenosis. Okay, so again, here's just another diagram of the heart. You have to figure out what works best for you in terms of visual study guides. For me, I found visual study guides extremely helpful. I found sometimes drawing diagrams such as the heart myself also very helpful. Getting a diagram that's blank and then labeling it yourself can also be a great way to retain information. Remember, pen to paper is extremely helpful in terms of retaining information. And one of the key things I want to reiterate with you guys in terms of your studying and your reading and all of this reading you're doing, it's not just about reading, it's also about retaining. So how do you retain the information? You have to figure out what works best for you. For me, I like to take my own outline notes. I would draw tons of diagrams. I would use a lot of pictures, draw pictures. I used a lot of highlighters and differentiated certain things with colors. Gold standards, I would, definitely highlight in yellow in my notes. So I always would make sure I knew my yellow gold standards for whatever, disease process I was dealing with or treatment guidelines I was looking at. So things like that will really help you study harder, not smarter. I'm sorry, study smarter, not harder, because you really want to try to figure out a system that helps you really quickly get that visual memory bank going when you have to retain so much information. Okay, so we got into chest pain, palpitations. This is your basic review of your common cardiac complaints. That was from chapter 34. Remember, palpitations versus chest pain. You want to make sure you're understanding that the palpitations for a patient is usually described as an awareness of them feeling their own heart beating. Okay, in the next slide, we have here a beautiful diagnostic reasoning algorithm that's right out of your textbook, but I really wanted to point it out because this is going to help you differentiate and give you differential diagnoses in terms of the chest pain and where it's located, on what aggravating factors, and then it'll give you the next step in terms of what is the highest priority to rule out based on what your patient is presenting with. So this is an excellent tool to review from, study from, memorize, draw yourself, and color code it yourself, however you want to do it. But this is an excellent resource in terms of studying and reviewing the differentials that are associated with chest pain. And it's not just about chest pain, it's understanding how your pulmonary emboli would present versus your pericarditis versus your angina. This is an excellent way to study and use a concept map to really differentiate the chest pain differentials. Again, here's another one in terms of palpitations. So palpitations can bring out a whole nother group of differentials, including, anemia, hyperthyroidism, mitral valve prolapse. So these are, again, things you need to be able to differentiate and just know at the back of your head, like, oh yeah, that's right. Anemia, that can be associated with palpitations. What am I looking for? Signs and symptoms: fatigue, dyspnea on exertion, pallor. Okay, these are things to just really start to look at these types of algorithms and concept maps. You may even want to create a file that you will have on hand for when you do start practicing, because again, there's nothing wrong with having these tools available to you to really, really make sure you're giving the best standard of practice of care to your patients. Okay, syncope and dyspnea. We reviewed that. Remember, syncope is a loss of consciousness that occurs abruptly, and cardiac related syncope is an ominous sign. Ominous sign meaning it's not a good sign. Bad things are about to happen. Prepare yourself. Let's get this patient, to the ER immediately. Dyspnea, shortness of breath, one of the most common cardiac symptoms. Again, that's why you're pulling out these algorithms to really start ruling out, okay, dyspnea is very common. Dyspnea can go with a million different diagnoses. Where do I even start? So you're looking at these types of algorithms and you're giving yourself options and really making sure you're differentiating the highest priority diagnoses to rule that out, to make sure your patient is, making sure you're ruling out the worst case scenario for them. Leg aches and peripheral edema. So leg aches are usually caused by an impaired blood flow to the extremities. We can have various reasons for it: arterial vascular disease, venous problems, chronic venous insufficiency, as well as varicose veins. Associated with leg aches sometimes comes peripheral edema, which is the accumulation of tissue fluid within the interstitial spaces of the extremities. And it's usually diagnosed via history and physical exam. Although laboratory findings may also assist in determining the causes of edema, it is essential that you as the NP figure out the underlying cause and identify it and treat it, or the peripheral edema could remain, and that would possibly cause tissue ischemia from compressed and diminished arterial circulations. So when you're trying to rule out, when it comes to peripheral edema, specific diagnostic tests that you would want to consider in terms of ordering would be a CBC, your urinalysis. You want to do serum chemistries, a thyroid profile. You also may want to consider an X-ray if there's been any trauma to that particular extremity, or if you suspect any osteomyelitis. You should also consider a chest X-ray film in order to assess the heart and lungs, because if we have all this swelling in the legs or in peripheral edema, where is it coming from? And are we building up fluid around our heart and lungs? So we definitely want to rule that out. You may want to do an EKG just as an essential for assessing your cardiac function. And of course, Doppler studies may be ordered to evaluate for deep vein thrombosis or DVT. Okay, so in figure 34.3 and table 34.3 in your textbook listed, and I have a copy of it right here. This also is a diagnostic algorithm for peripheral edema. Again, look how beautifully this is laid out for you. All right, our patient's presenting. What do we have going on? Is this a new onset peripheral edema, or is this something that's chronic for this particular patient? And based on that, you take it from there, and you can go, you can rule out step by step based on your patient's presentation. So make sure you review these, because again, it's also reviewing your differentials that you also want to keep in mind in terms of differentiating one thing from another. So here we have hyperthyroidism versus lymphedema versus cellulitis versus deep vein thrombosis. So we have lots of reasons or causes of peripheral edema, but we need to rule it out and we need to treat so that things don't get worse. All right, hypertension and dyslipidemia. So hypertension, we know, is one of the most common chronic health problems. Management includes weight reduction, sodium reduction, and increase in physical activity, as well as, of course, stopping smoking cessation. Dyslipidemia is the elevated concentrations of any or all of different types of lipids in the plasma. So things to keep in mind in terms of hypertension, we have essential hypertension versus secondary hypertension. Essential hypertension describes high blood pressure that has no identifiable etiology after a thorough clinical examination and excludes possible secondary causes. The etiology and pathophysiology of essential hypertension are incompletely understood. There's a lot of complex genetic and environmental factors, as well as diet and lifestyle practices, imbalances in vasoactive substances. And although the precise cause of essential hypertension is unknown, they do feel like endothelial dysfunction is like the key thing involved in essential hypertension. Endothelial dysfunction is central to many cardiovascular disorders, including hypertension, atherosclerosis, and myocardial ischemia. The other hypertension that we have classified as secondary hypertension. Secondary hypertension is elevated blood pressure due to an identifiable and underlying condition. Detection of secondary hypertension is critical to reverse the source of the pathological process and prevent hypertensive target organ damage. Much less common than essential hypertension, secondary hypertension has an overall frequency of between 5 to 10% in primary care practices. And basically, the way you differentiate secondary hypertension from essential hypertension is by certain assessment findings, such as the age of onset, younger than 30 or older than 50, blood pressure higher than 180/110 at diagnosis. Things like that will differentiate whether it's essential versus secondary. Let's see. So again, another table in box 35.1, definitely review that in terms of hypertension. You want to make sure you're reviewing the drugs commonly prescribed for hypertension is listed in the tables in your book. Dyslipidemia, also table 35.3 and 35.4, and please review the drugs commonly prescribed for statin therapy. Keep in mind, approximately 1 in 5 adults will need treatment for hypertension, and the key to hypertension management is not only the reversal of hypertension-related disease trends, but also the prevention. So, there's lots of guidelines and public health guidelines out there specific to managing and treating and prevention of hypertension. Please review the use of lifestyle modifications in box 35.2 in your book as well, which should be part of every patient's regimen to prevent or treat elevated blood pressure. You want to make sure that as the patient's primary care practitioner or nurse practitioner, that you're working with the patient on a plan of lifestyle modification and medications as needed to lower the blood pressure as much as the patient can tolerate it without symptoms. You want to make sure patient-specific goals include, increasing their awareness of the risks of hypertension, understanding what their BMI is and what it means and how to guide them to, go for weight loss rather than just, you know, uh, aiming for an ideal weight. You want them to understand the importance of bringing down their BMI and what that means on their health. You want to make sure you're talking to them about improving hypertension control, specifically with your patients who have already been diagnosed with hypertension. Okay. You want to make sure they're staying within their diagnostic thresholds. In table 35.1, it lists, where do you want to keep these patients to keep them under enough control that is limiting or, decreasing their risk factors for, any serious complications. You want to obviously reduce their cardiovascular risks as well as their high blood pressure risks. Many patients with hypertension will have additional modifiable cardiovascular disease risk factors such as diabetes, high cholesterol, smoking cessation, physical inactivity. Therefore, you have to come up with a really comprehensive plan for these patients to treat the hypertension and address these particular issues. Keep in mind, there are, like I said before, lots of guidelines out there to guide you in terms of high blood pressure management or hypertension management in your patients. But in 2014, the Public Board of Health panel appointed the 8th Joint National Committee, or the JNC8, which published recommendations for hypertension to guide the healthcare practitioners on treatment guidelines. So I have uploaded in your modules the JNC8 guidelines. It's listed right above your PowerPoint presentation for download. Please download that and review it. I have it here in the module. I'll get to that slide, but it only has the first slide. The second slide is within that document. So please, please, please look at it. It's so helpful in just totally summarizing and giving you key tips on your path for how you treat hypertension. Okay, so here's your lifestyle modifications. Again, that's box 35.1. Very basic stuff, but make sure you understand it, know it, and understand it enough so that you can actually teach your patients these particular things. Here are your JNC, what I just mentioned before, that's within your module. It's your JNC8 hypertension guideline algorithm. This gives you the perfect guide to, really give you very exact information on what you will be doing with your patients based on their factors. So based on age, based on their blood pressure, based on their race, based on if they have diabetes or CKD. So you're reading this algorithm, make sure you're understanding and really remembering in the back of your mind what the criteria is that is based around this algorithm in terms of these guidelines. That's a very important thing to remember. So when you're considering, why are the JNC hypertension guidelines, so important? You have to remember what the algorithm actually is looking at in terms of the patient. So first of all, you're looking at the age. Is the patient over 18 years old? Okay, so the first thing we're going to do is, they're 18 years old. We're going to implement lifestyle modifications, set a blood pressure goal, initiate blood pressure lowering medication based on the algorithm. Okay, so that's the first thing. The patient's over 18. Now, does the patient have diabetes or CKD? No. If no, we go into the green boxes. If yes, if diabetes or CKD is present, then we go into the red boxes because that just upped our risk factors, correct? So these are the factors that the guidelines are looking at, whether it's JNC or any other guidelines. The majority of them all look at these particular differentiating factors. So make sure you are aware of them. Again, age. Does the patient have diabetes or CKD? Is the patient Black or is the patient African-American or not African-American? Okay, these factors are really going to influence how you treat your patient. All right, so again, download this algorithm. It has 2 pages. The second page is actually extremely helpful as well. It breaks down the medications and it gives you compelling indications. It talks about the different drug classes, the agents of choice, and references comments regarding each medication choice and why they may be contraindicated. It's a lot to remember, but once you get the hang of it, and again, you break it down based on these certain criterias, it will all start to come together in terms of those critical thinking questions. Okay, next, we're getting into the potential causes of secondary hyperlipidemia. So these are the risk factors. What can cause your cholesterol to be abnormal. And these are the risk factors, guys. It's pretty consistent across the board. These risk factors are risk factors among most of the disease processes. So you're going to start to see certain things repeating themselves over and over again. Inactivity, smoking, alcohol abuse, diabetes, hypothyroidism, renal insufficiency. Again, know these factors, understand how it's going to cause the cholesterol to fluctuate. So inactivity causes our HDL to go down. Alcohol abuse causes our triglycerides, our HDL, and our LDL all to go up, okay? Diabetes, it causes our triglycerides to go up, our HDL to go down, and our TC to go up, all right? Make sure you understand these causes and what it does to the lipids. Okay, coronary heart disease and acute coronary syndrome. So coronary heart disease, make sure you understand contributing risk factors. Again, these risk factors come up over and over again. So diabetes, obesity, obviously stress. Management would include controlling symptoms, stent placement, CABG, or fibrinolytic agents. And then, of course, we have acute coronary syndrome, which is the disorder of myocardial ischemia. So in terms of treatment of myocardial infarction, remember, treatment is really based around the location and extent of the damage of the infarcted myocardial tissue and the speed with which the reperfusion is supplied to the cutoff areas of the myocardium determine the prognosis following an MI. So basically all that means is the quicker you can treat these patients, the better off they're going to be, just like anything else, right? Because the use of early reperfusion therapy increases the likelihood of survival and it improves left ventricular function, the patient with a suspected MI should be assessed rapidly in order to provide the most appropriate care. So this is why I really wanted you to look at those algorithms to make sure, once again, that you are making sure you're differentiating your diagnoses and prioritizing what the worst case scenario could be first, rule that out, and then move on from there. Okay. Again, you're going to want to look at table 35.4, that treatment flow chart in terms of unstable angina. In terms of acute coronary syndrome, the basic treatment and the pharmacological treatment of ACS is directed primarily at the dissolution of the intracoronary thrombus causing obstruction to blood flow by antiplatelet therapy. So aspirin or heparin, those are types of antiplatelet therapy. And then, of course, the relief of symptoms, we would use things like nitroglycerin, supplemental oxygen, morphine, to just relieve the symptoms of the chest pain. And then after the MI is confirmed, we need urgent evaluation for salvage of viable myocardial tissue, which is initiated through reperfusion treatments based on coronary angiographic studies. Ultimately, the goal of management is to salvage the ischemic myocardium before it becomes necrotic by reperfusing the area as soon as possible. After you try to reperfuse that, ischemic muscle, after that, the goal after that is to keep treatment going to prevent any future attacks. All right, so then we have coronary heart disease. Please make sure you're reviewing your coronary heart disease risk factors, including non-modifiable versus modifiable. Remember, in CHD, your non-modifiable risk factors include male gender. Can't change that. And not only are these non-modifiable, but these are the risk factors for CHD. So your risk factors for coronary heart disease include a male gender, increasing age, family history of CAD, and African-American ethnicity. So not only are those risk factors, but they are non-modifiable risk factors for CHD versus your modifiable risk factors for CHD, which include hypertension. Remember, hypertension is 140, any blood pressure greater than 140 over 90, depending on the age for the most part, but really hypertension, you've reached it once you hit 140 over 90, okay? So again, my modifiable factors include hypertension, smoking cessation is key in every disease process, sedentary lifestyle, and high cholesterol. These are all your modifiable risk factors for coronary heart disease. Make sure you review those, please. For women, natural or surgical menopause without estrogen replacement therapy, or oral contraceptive use combined with cigarette smoking are also modifiable factors that put women at higher risk for coronary heart disease. Also contributing risk factors for CHD, like I said before, diabetes mellitus, obesity, and stress, all are contributing risk factors. For acute coronary syndrome, please make sure you review again the table 35.5 to differentiate between the different forms of angina. So forms, in terms of differentiating and treating your different forms of angina, you want to make sure you're able to differentiate between stable chest pain, your duration, your relief versus unstable, and how that duration and relief differentiates from stable. So stable versus unstable. Remember, stable chest pain, it usually is transient episodes related to activities that increase myocardial oxygen demand, versus unstable chest pain, which is more severe and brought on with less exertion and may occur at rest. You definitely want to make sure you look at table 35.7 also to differentiate your heart failure and your classification of heart failure severity, as well as staging criteria for heart failure based on the New York Heart Association. Very important because, again, understanding the staging and classification of severity will help guide you in terms of your diagnostics and treatment. Do not ignore the signs, of course. Although chest pain can be caused by a number of conditions, you also want to make sure you're assessing for acute coronary syndrome in the patient with angina pectoris. It's very crucial because given the life-threatening implications of an MI, the diagnostic workup of a patient with suspected ACS must always rule out infarction, okay? The most specific laboratory tests to rule out MI are cardiac-specific troponin, and these troponin 1 and troponin CTNT. These troponins are cardiac proteins released from dead heart muscle, and they are essentially undetectable in the blood of healthy individuals. Troponin levels rise within the first 2 to 4 hours after an MI and remain elevated for 7 to 10 days. So just keep that in mind. EKG changes are transient. Keep in mind, an EKG only shows you what is happening in that moment during the acute event and sometimes during tissue healing. Thus, if it's not found during the acute presentation, you may miss it. All right. So you may need to do an EKG every 15 minutes, really to pinpoint what's going on in the beginning until you really are sure what your diagnosis is. The terms Q wave and non-Q wave MI are now referred to as STEMI and non-STEMI. There may be a temptation to consider a non-Q wave as a small heart attack. However, that's not really the case. The majority of patients with non-Q wave MIs are elderly, you're usually between 70 or older, with a history of prior MI and CHF. Please make sure you review table 35.3 in your book, which differentiates between a STEMI versus a non-STEMI and the EKG changes. In table 35.2 as well, it gives you more of a typical EKG view of changes seen with cardiac damage. So heart failure, again, systolic versus diastolic dysfunction. We have right-sided heart failure versus left-sided heart failure, right ventricular versus left ventricular failure, and forward versus backward failure. The management of heart failure focuses around decreasing cardiac workload, optimizing LV function, and controlling any atrial fibrillation. Heart failure severity has traditionally been described with the symptom-based New York Heart Association classification system. So that's the NYHA classification system, and they classify heart failure based around the severity. And it's basically 1, 2, 3, 4 levels. Level 1 is patients that are asymptomatic with heart failure, so they're at the very beginning. And then you have your worst case, which is stage 4, or classification 4, which is patients with heart failure who have symptoms that are very severe, specifically at rest. So again, that's your New York State, your New York Heart Association classification of heart failure severity. It goes from level 1 to 4, 1 being asymptomatic versus 4 with symptoms at rest. And then you have the ACC or the AHA guidelines that also supplement with the New York Heart Association in terms of staging. And their system stages the progressive phases of heart failure. Their staging criteria goes A, B, C, D, and it's also 4 levels, but instead of level 1, 2, 3, 4, now we're talking A, B, C, D. And again, their level A is patients just at risk for developing left ventricular dysfunction, versus level D is patients with refractory end-stage CHF. So again, it goes from the least to the worst. So by assigning a combination of both, the severity level versus the staging level, you can be more exact in your assessment, and subsequent management a subsequent management plan can be implemented. Keep in mind, with these types of patients, obviously they're going to have a cardiologist involved. You're going to have already made that referral. But the idea is the cardiologist and you are going to be collaborating and for that particular reason, you need to know what the severity and stage of your patient's heart failure is, so that you and the cardiologist are on the same page as to what the basic standards of practice are to treat these particular patients, and also what the realistic expectations for these patients are based on their severity and staging. Again, when you're managing heart failure as the primary care practitioner, you want to consider treatments that are going to decrease the cardiac workload, decrease the volume overload, optimize the LV function, reduce mortality, and control the ventricular rate, or convert AFib to a sinus rhythm. You're really making sure these patients' weight is very much monitored very closely. You're doing a lot of teaching with these patients, especially about symptom management and self-assessment at home. Okay, these patients, especially as they get more severe and later on in their staging of heart failure, you really want to start considering home care services, whatever types of supplementary services and assistance these patients can get to reduce hospitalizations and heart failure exacerbations is really, really what critical in putting in place for these particular patients. Okay, arrhythmias. So we're looking at atrial arrhythmias versus ventricular arrhythmias. We are also looking at the pathophysiology, common mechanisms, as well as diagnostic tests, your EKGs, TEEs, as well as management of AFib, heart blocks, implantable, and use of implantable cardiovascular defibrillators. So, next page. Okay. So we have types of valvular disorders, which include aortic stenosis, mitral regurg, and mitral valve prolapse. We have types of murmurs, which include benign systolic ejection murmurs, hemic murmurs, aortic sclerosis murmurs. The important thing is you really need to make sure you are able to differentiate heart murmurs, guys. So let's start from the basics in terms of just being able to differentiate murmurs. There's 2 pieces of information that you need to make sure you know. You want to look for the timing of the murmur. So is it in systole or is it in diastole? Those are the first 2 things you need to understand. Where is the murmur being heard, during systole or during diastole? Remember, systole is during the lub of your S1 versus diastole is dub in S2, okay? After we figure out the timing of the murmur, whether it's happening in systole or diastole, then we need to look for the location of the murmur. Is it at aortic? Is it aortic? Is it at Erb's point, or is it the mitral area? Okay, so again, first we're looking for the timing. Is it systole or diastole? Then we're looking for the location. Is it aortic, Erb's point, or mitral areas? And then based on those 2 things, all the murmurs seen on exams will fit into 2 categories. And the categories are based on 2 different mnemonics. So I want you to make sure you look into this or you review this. Timing of murmurs is based on either systolic or diastolic. So if it happens in the systolic time, if the murmur occurs during systole, you want to use the mnemonic Mr. ASS, okay? The M stands for mitral regurg. I'm sorry, the MR stands for mitral regurgitation. The A stands for aortic stenosis systolic, okay? That's the mnemonic for systolic murmurs. Versus diastolic murmurs, you want to use the mnemonic MIS-ARD, MS.ARD, okay? That's mitral stenosis, atrial regurgitation, diastolic pneumonic, okay? So this is how you're going to differentiate, because keep in mind on your exams, on your test questions, even if you can't differentiate this by sound, which I hope you will, because that's very important upon assessment, that you're able to differentiate these murmurs. But even if you can't, if you can learn these mnemonics and how they are described based on these mnemonics, you will be able to differentiate them within a critical thinking question. And they do have these questions on the boards. So please, again, learn to use the mnemonics Mr. Ass and Miss Ard. Okay. All murmurs with mitral in their names are only described as located, okay, on the apex or the apical area of the heart, or on the fifth intercostal space. Remember again, S3 is a sign of congestive heart failure versus S4 is a sign of left ventricular heart failure. You also need to make sure you remember how to grade your murmurs. Heart murmurs are on a grading system, grades 1 through 6. Okay, grade 1 being a very soft murmur heard only under optimal conditions, versus grade 6, where the murmur is so loud that it can be heard even with the stethoscope off the chest and the thrill is easily palpitated. Okay. Okay, so here's just a visual of the normal aortic valve versus an aortic valve with stenosis. I find that, really differentiating these different types of murmurs and, how they're affecting the actual valves is very helpful when you have a kind of a visual guide of what's normal versus abnormal. And again, normal aortic valve here is nice and open versus an aortic valve with stenosis where it becomes narrow and stiff. That's what you start to look like. So think about the difficulty of circulation with this type of valve. Here we have a normal mitral valve versus a mitral valve with a prolapse. The prolapse valve is not able to close completely. So think about that when you're thinking about the heart and how the blood is circulating. In terms of a mitral valve prolapse, this is what the valve would look like versus an aortic valve stenosis where it's becoming stiff and narrow. Again, here's more of a visual guide. Again, stenosis, it doesn't open properly. That valve is like kind of clogged and it's stiff and it's not opening properly, versus regurgitation. We have a valve that doesn't close properly. It's kind of floppy and flappy. So it's really not doing its job properly. Again, here is how we're differentiating. You can use your mnemonics to help you with this, or you can just kind of try to remember. I find the mnemonics much more helpful, but here it's all listed out. So your mitral valve regurg versus your mitral valve stenosis. Here's the timing of where your murmur would be, the location, and your most common causes. But that's how your questions are going to be differentiated on your exams, whether it's, for quizzes, exams, your boards, and of course in clinical practice. You need to know how these valves are presenting clinically. So if we know the disorder and we know the timing and we know the location, then we can already, memorize the common causes. And if we consistently remember these, timings and locations, it will all start to, kind of pop in when you put that stethoscope on the chest and you can hear the timing. You already know where your stethoscope is located in order to hear these particular sounds. So once you really start to get a grasp on understanding the differentiation of timing and location of these particular murmurs, the common causes, and you just remembering which valve is being affected will start to click. Okay, disorders of the vascular system. We have peripheral artery disease, in which we have an inclusive disorders of the arteries, most commonly affecting the lower extremities. Your typical diagnostic text would include Doppler ultrasound. We definitely want an ABI, which is arterial blood. What is ABI? I'm sorry, ankle brachial index, which is used to evaluate the severity of PAD. Remember, in terms of your ankle brachial index, a score of less than 0.9 is diagnostic for PAD. and a score of less than 0.5 indicates severe arterial disease, in which we would want to refer to a vascular specialist. An ABI, or an ankle brachial index score of 0.91 to 1.3 is considered normal. Keep in mind, peripheral artery disease is, blood flow to the extremities gradually decreases over time, which results in ischemic damage. And in these patients, we really worry about gangrene of the toes and the feet. Of course, again, your higher risk factors for peripheral arterial disease include hypertension, smoking, diabetes, and high cholesterol. That's kind of why we group these particular things all together in terms of knowledge base and just understanding things, because they all go so closely together. Peripheral artery disease is previously known as peripheral vascular disease. So just keep that in mind. They go hand in hand, PAD versus PVD. Most patients that you're going to see with peripheral vascular disease or peripheral artery disease are usually your older patients with that history of smoking and hyperlipidemia. And they basically present with worsening pain on ambulation, also known as intermittent claudication, that is usually relieved by rest instantly. Okay. Over time, though, the symptoms can worsen until the patient's walking distance is greatly limited. And then we start to get atrophic skin changes. And again, we get those gangrene on one or more toes. Usually on these patients, they present with shiny and hyperpigmented ankles that are hairless and cool to the touch. You could also see gangrene on the toes. Cardiovascular, these patients usually have a decrease to absent dorsal pedal pulse, and they have an increased capillary refill time and bruits over partially blocked arteries. In terms of the ABI, or ankle brachial index, guys, it's done on each ankle. And basically, they take the systolic blood pressure of the ankle and the arm, which is brachial, and is checked after being in a supine position for 10 minutes by using a blood pressure cuff and an ultrasound probe. And basically, they're dividing the highest systolic blood pressure measured on each arm. You choose the higher BP, and by the highest systolic blood pressure of each ankle. So that's how they figure out the average. So the treatment plan for peripheral artery disease includes encouraging smoking cessation, because remember, smoking causes vasoconstriction. You want these patients to have daily ambulation exercises. You want to consider treatment with Trentol if it's indicated, or Pletol, which is a direct vasodilator, which can be taken with aspirin or Plavix. Some, complications of peripheral artery disease include gangrene, increased risk of coronary artery disease, and increased risk of carotid plaquing, which is where you'll feel like the carotid bruits. So deep vein thrombosis, or chronic venous insufficiency, it's characterized by, a DVT is characterized by clot formation in deep vessels of venous vasculature. Chronic venous insufficiency is characterized by valvular incompetence. And management of DVTs includes anticoagulation treatment, LMWH management. For chronic venous insufficiency, it's a little more conservative. Keep in mind, in terms of deep vein thrombosis, thrombi develop inside the legs or pelvis secondary to stasis or trauma to a vessel, inflammation, or increased coagulation. Pulmonary emboli is considered another manifestation of this thromboembolic disorder or deep vein thrombosis. So there's three categories of deep vein thromboses. There's three etiologies that there are. There's three different ones. So one is stasis, where you just prolong travel or inactivity for more than 3 hours. So a stasis DVT would be like somebody who's been sitting on an airplane for 3 or 4 hours. Somebody who's got inactivity like bed rest or congestive heart failure, because they sit a lot. They tend to have, a very much dependent pitting edema. So there are very high risk for stasis deep vein thrombosis. We also have our inherited coagulation disorders like factor C deficiency, Leiden, and so forth. And then we have our increased coagulation due to external factors. That's another category of a cause of a DVT. So things like oral contraception, pregnancy, bone fractures, especially of the long bones, trauma, recent surgery, and malignancy. I've said this before, guys, a clinical pearl. If you start to see one of your patients throwing a lot of clots out of nowhere for no particular reason, you need to think cancer, okay? You want to rule out cancer. Malignancies of any type, specifically cancer, have a tendency to manifest with, at first, before anything else, with random frequent blood clots. All right, guys, so just make sure you keep that in the back of your head. Again, the three etiology categories of DVT include stasis, inherited coagulation disorders, and increased coagulation due to external factors. All right. So treatment plans with DVTs would include, diagnostics would include CBCs, platelets, clotting times, including your PT, PTT, INR. You want to get a D-dimer level, a chest X-ray, and an EKG. You may need to do an ultrasound of the leg or whichever leg, both legs if necessary. You may need to consider hospital admission so that you can administer low molecular weight heparin via IV, and then you would taper them onto Coumadin for at least 3 months to prevent any further clots from reoccurring. For recurrent DVT or elderly, antithrombotic treatment may need to be forever, may last a lifetime. Complications are pretty severe when it comes to a DVT, so keep that in mind. DVT can lead to pulmonary emboli, which can lead to death, as well as stroke and other embolic episodes. You want to definitely make sure you review your DVT risk factors, guys. So again, here are some more places just to focus on. Peripheral artery disease. We want to make sure we're looking at the risk factors for arterial versus venous risk factors. We want to make sure, again, we're looking at our risk factors for DVT. Make sure you review Virchow's triad and make sure you're very clear on what you're educating your patient on in regards to DVTs, prevention, and emergency symptoms to report. Knowledge review. Okay, guys, as a 73-year-old male who is a smoker and has a BMI of 28 and is newly diagnosed with primary hypertension, has a history of emphysema and second-degree AV block. Okay, so we've got a lot going on with this guy. He's newly diagnosed with primary hypertension, history of emphysema, and second-degree AV block. So already we know he's got some cardiac and respiratory issues. So we have to be very conscientious of that in terms of prescribing for our patients with high blood pressure. Again, look at that JNC 8 guideline. It will guide you in terms of looking at the side note of somebody with COPD as well as any kind of heart failure or heart block. His blood pressure from the previous visit is 145/80. During the current visit, his blood pressure is 155/80. What is the next step? Okay, so first of all, this guy has a lot of risk factors, so we don't want him walking around, especially if he's 73, he's a smoker. His BMI is a little bit up there. He's newly diagnosed with hypertension. So that means he's probably been walking around with an elevated blood pressure for quite some time. And now we're finally trying to treat him, but it's still not quite under control. On top of that, he's got a history of emphysema and AV block, second degree, to say the least. And he's walking around with 155/80. So we definitely need to manage this. We definitely need to get this under control at multiple levels, but in particular, what is the next step in terms of what this question is asking? Okay. So that's A, start patient on Atelol, 50 milligram once a day and reassess in 3 months. B, start the patient on Cabrin, 2.5 milligram once a day and reassess in 2 months. Or C, start the patient on chlorthalidone, 12.5 milligrams daily and reassess in 1 month. Or D, no medication is needed at this time. All right, let's see. The correct answer is C, start the patient on chlorthalidone, 12.5 milligrams daily and reassess in 1 month. Okay. So again, for patients newly diagnosed with hypertension, if you look at your JNC guidelines, the JNC guidelines recommend follow-up visits every month, 4 weeks to reassess blood pressure in a newly diagnosed patient with hypertension. Guys, if you didn't even know which medication to choose from, again, let's go back to just basic test taking tips, all right? In terms of just keeping your highest priority things and just really being conscientious of these particular patients. If we know he's newly diagnosed, first of all, and he already came in before at 145/80 and he's still up there, do you really want to wait 3 months before you recheck this guy? He's 73, he smokes, he's got an elevated BMI, he's newly diagnosed, he's got a lot of pretty high, risk comorbidities, including emphysema and second-degree heart block. Would you really think it was appropriate to wait 3 months, 2 months, or no, nothing at all. I mean, just from that alone, just from knowing that I need to reassess this patient sooner than later, I would have guessed C, even if I didn't know any of these medications or what the appropriate medication would be for him in terms of treating hypertension based on his history of emphysema and secondary heart block. All right, so just keep that in mind. You know, we don't want this guy running around for a long time with that elevated BP, right? So the sooner I can get him in here, the better. So that's, you could have looked at from just a basic test taking standpoint. All right, guys, just a side tip. So again, we're going to want to check him every 4 weeks until that blood pressure is under control. When the blood pressure is at goal, which is less than 130/80, the visits can be done every 3 to 6 months. The patient has emphysema, so beta blockers are not allowed, which would include tenormin and atenolol, or, you know, tenormin is the brand of atenolol. He also has a second-degree AV block, which is a contraindication to calcium channel blockers, which would be felodipine. All right, so just really look at those guidelines, guys, and what medications are contraindicated based on, you know, any kind of respiratory or heart conditions. All right, last slide, just to review in terms of danger signals and high priority diagnoses that you need to make sure you're ruling out or you're looking at the warning signs for. That would include, which we already talked about, your acute coronary syndrome, which includes your STEMI versus your non-STEMI. Make sure you're able to differentiate that both in clinical manifestations, diagnostics, and what you're looking at on an EKG rhythm. I will tell you on your boards, depending on which boards you take, the likelihood is you will get 1 or 2 EKG rhythm strips that you will need to identify and do some critical thinking about. Again, they're not really so much looking for you to be able to interpret EKGs as being able to just differentiate a dangerous arrhythmia and being able to just quickly be aware of it and be able to diagnose it. All right, so you're looking at STEMI versus non-STEMI. You want to be able to differentiate between stable and unstable angina, because unstable angina, we worry about an MI. All right, heart failure, obviously you want to know the signs, the classifications, and the severities. You want to be able to differentiate infective carditis, also known as bacterial endocarditis. And there are certain very clear symptoms, clinical manifestations that you should be able to differentiate that would clue you into infective endocarditis, including fever, chills, a new onset murmur, weight loss, sudden weight loss, subungual hemorrhages, which are splinter hemorrhages on your nail beds, as well as violet colored nodes on the fingers and toes. Those are called Osler nodes. When you see this, these are ominous signs, guys, very, very important. You do not ignore them, and you rule these patients out for specific things like bacterial endocarditis or any kind of heart failure issues. And then, of course, we have another very high priority, dangerous diagnosis, AAA, abdominal aortic aneurysm. A lot of these patients, majority are asymptomatic, or they come in with severe, sharp, excruciating pain in the abdomen and flank. In about half of these patients, not all, but in about half of them, you will be able to palpate or pulsatile abdominal mass in about 50% of these patients. So just keep that in mind. Initial test for this is an ultrasound, but you do want to rule this out immediately because it is deadly. All right, guys. Next week is module 9. We are getting there. We're getting through this. I'm so proud of you all. Next week, we are doing hematology. In terms of this week, please look at your YouTube videos, supplementary videos I uploaded. There's some great, just short videos that offer some great pinpoint information to help kind of solidify a lot of this stuff to hopefully help you guys retain it and just get you through your quizzes and your next exam as well as your boards. And hopefully it'll help in your clinical practice as well. All right, have a great week, everybody. If you have any questions, please feel free to email me, jstone-lanfranchi@goodwin.edu. Thanks, guys. Have a good week.